everyone.
Here is our specimen for today. And I'll just move it around a bit so everyone can see it first. And then I'll put up our first polling question. So what type of specimen is this? Okay, and I'm going to end the polling question there and share the results. So great job, everyone. Yes, it is a total hysterectomy with bilateral self-injectomy. So here are the different types of hysterectomy specimens. So a total hysterectomy specimen includes the removal of the uterus and cervix, and this can be done for either benign or malignant conditions. A self-injectomy is the removal of one or both fallopian tubes. An oophorectomy is the removal of one or both ovaries. And then a radical hysterectomy is the removal of the uterus, cervix, as well as the vaginal cuff, parametrium, and the regional lymph nodes, and typically also the fallopian tubes and ovaries. And this is typically done, these radical hysterectomies, for malignant conditions, particularly for cervical carcinoma. So with our case here, we have our uterus and our cervix, and then both fallopian tubes. So the uterus is a pear-shaped organ that plays a critical role in menstruation, fertility, and pregnancy. It's located within the pelvic cavity between the urinary bladder, which lies anterior to the uterus, and posterior is the rectum. Connected to the lateral sides of the uterus are the fallopian tubes and ovaries. And at the distal end of the fallopian tubes are the fimbria, which you can see here. So at the base of the uterus is the cervix, and this can be divided into two main parts. So the endocervix, which is the inner part of the cervix that leads into the uterus, and the ectocervix, which is the outer part of the cervix. The junction between the endocervix and exocervix is the transformation zone, and this area contains both glandular cells from the endocervix and squamous cells from the ectocervix. The opening into the uterus is called the internal os, and the opening into the vagina is called the external os. Between the internal os and external os is the endocervical canal. And another important landmark to identify is the lower uterine segment, which lies right above the cervix. So now I have a picture here of a uterus specimen that I've labeled just to show you all these different anatomical regions. And just to orient you all, so this is one half of the uterus showing the inside. So the top 2/3 is the body of the uterus. And then the lower 1/3 is the cervix. The most superior aspect is the fundus. And then the most inferior aspect is the ectocervix, which connects to the vagina. So this triangular shaped area here is the endometrial cavity, and that houses the endometrium. So the endometrium is the mucosal layer lining the uterine cavity composed of endometrial glands and specialized stroma. Then we have the myometrium here, which is the muscular layer of the uterus composed primarily of smooth muscle. And then the outside, we have the serosa, which is the thin outermost layer of the uterus, which you can see on our specimen here, but not really on the picture there. And then the endocervical canal. And then right above that endocervical canal is the lower uterine segment. So for our specimen today, we have the body of the uterus here, the cervix, the fundus, the ectocervix, with the external os here. And then going inside, then we have our endometrial cavity, which you can see this triangular shape here. So our endometrium is in there. Our myometrium is all this muscle here. Our endocervical canal is here. And then our lower uterine segment is here. So now I'll put up our next polling question here. So what is the correct order of annexa structures from anterior to posterior? Okay, so I'm going to end the polling there and share the results. Yes, so great job, everyone. It is C, so it goes round ligament, fallopian tube, ovary. And so another way that we can orient these specimens, if we don't have the annexa, which would be the case for our specimen here, we only have the fallopian tubes. So we don't have the ovaries or the round ligaments, so we can't orient it using the annexa. We would have to use the peritoneal reflections. So typically the anterior surface, the peritoneal reflection, is rounder and higher up. And this is because this is where the bladder would sit right here. All of this cauterized area is where the surgeon would have removed that bladder from. And then the posterior side is typically the peritoneal reflection comes down lower and is more pointed in its appearance. And this would be where the rectum would connect to. So for our specimen, we have our anterior and then posterior. So our specimen today is a benign hysterectomy specimen out for pelvic pain. So some other benign conditions that we could receive hysterectomy specimens for include leiomyomas, endometriosis, adenomyosis, pelvic pain, irregular bleeding, prolapse, placenta accreta, increta, or percreta. And I'll put up an image here showing one of these, and then put up a polling question in relationship to it. So what pathology is shown in this image? Okay, so I'm going to end the polling there and share the results. So great job, everyone. It is adenomyosis. So adenomyosis is defined as the presence of endometrial tissue within the myometrium. So for gross features, typically these uterus are very enlarged and round. So you can see that in the top image there with that round uterus. As well, the myometrium is typically thickened, and the cut surface is trabeculated/lacy with cystic spaces. So you can see that bottom image there, that trabeculated lacy cut surface with all of those pinpoint cystic spaces. So another benign condition is endometriosis, which is defined as the presence of ectopic endometrial tissue at a site outside of the uterus. And the most common site of involvement is the ovary, which is seen as a chocolate cyst. So you can see that with the image there. So this is a benign ovarian cyst filled with old menstruational blood that is brown and tar-like in its appearance, which makes it look like melted chocolate. And that's where it gets its name from. So another common area for endometriosis to occur would be the posterior cul-de-sac. So that's just right at the posterior aspect here, right where that peritoneal reflection occurs. And typically this looks like kind of that black brown speckling that you can see on the PowerPoint screen there. So if we saw something that looked like that, we could be suspecting endometriosis. Now we'll talk about leiomyomas. So this is the most common uterine tumor. They're commonly also called fibroids. It's a benign mesenchymal tumor derived from smooth muscle. And there's 3 different types of leiomyomas based on their location. So there's subserosal, which arise under the serosa. Then we have our intramural, which are found within the walls of the uterus. And then we have our submucosal, which are found beneath the endometrium. So the submucosal fibroids, typically because they grow under the lining of the uterus, they can cause more bleeding issues, and as well, they can grow into the uterine cavity and can cause more fertility problems as well. So before we talk about the gross features for a leiomyoma, it's also important to know the differences in gross features from a benign leiomyoma versus a leiomyosarcoma, which is a rare malignant smooth muscle tumor of the uterus. So I'll put up our next polling question here. So which of the following is not a concerning feature for a possible leiomyosarcoma? Okay, and I'll end the polling there and share the results. So great job, everyone. It is C. So all of the other ones would be concerning features for a leiomyosarcoma. So if there was one very large myometrial lesion, or if there was extensive necrosis or more of an infiltrating appearance. So if you saw any of those gross features, you'd be wanting to sample it more heavily. So the gross features for a benign leiomyoma are typically well circumscribed, white, whorled, and rubbery cut surface. So you can see that on the image there in the PowerPoint. So all of those lesions there are very well circumscribed and white and whorled. So now we'll talk about opening/freshing these benign hysterectomy specimens. So we want to open the specimen along the coronal plane by inserting forceps into the external cervical os and cutting along the forceps to reveal the endometrial cavity. So I would do something like this. So here's my external os here, and I would put the forceps in, and then I would take my blade right along to make that cut all the way down. Another way to do it would be taking scissors and putting the scissors into the external os and then cutting along the lateral sides here. Either way, you just want to be able to expose that endometrium to formalin to allow it to fix properly. Now we'll go into the grossing steps for these specimens. So our grossing steps: identifying the specimen, main findings, additional findings, ink code, and section code. So at our institution, we use a template. So all of these will be like little template areas. So our first one is what the specimen includes. So that would be the uterus. So we'd give the measurements in 3 dimensions. So SI, AP, and ML. And then we also give the cervix measurement in length by diameter. And then the fallopian tubes. So this one would be our right fallopian tube. So we'd give its measurement in length and diameter. And then this one would be our left fallopian tube. So we'd give its length and diameter as well. If we had the ovaries, we'd give its measurements as well. And so main findings will state if the uterus is intact or fragmented, talk about the serosa, talk about the external os, so if it's patent, and the shape of it. And I'll put up our next question in regards to this. So what does a slit-shaped cervical os indicate? Okay, so I'm going to end the polling there and share the results. So great job, everyone. It is C. So it is a woman who has given birth vaginally. The nulliporous woman would be more of a round os. So that is a woman who has not given birth. And so for our specimen here, we have a round os here. So this patient has not given birth. And here's just an image just showing those differences. So you can see that round os at the top and then the slit os at the bottom there. So we'd also be wanting to talk about our ectocervix. So all here. And then our endocervical canal. So if there were any polyps or anything, we'd be mentioning that, or any cysts. Our main findings continuing will be the endometrium. So what it looks like in its color. So this one's kind of brown tan. And then we'd be giving its thickness. And I'll have a few images later coming up about how to exactly get this thickness. And then if there were any abnormalities, so if there was a polyp, for example, like the one shown on the PowerPoint there, we'd be wanting to give its size, its location. So if it's located on the anterior half or posterior half, its depth of myometrial invasion, if applicable. So this is only usually for cancer. If it's involving the lower uterine segments, if it's involving the cervix, and if it's involving the margins. So for myometrium, again, we'd be wanting to give that thickness, and then we'd be giving the number of lesions, so the number, size, and consistency. So these ones are well circumscribed, white, and whorled. We'd be saying if there's any necrosis, hemorrhage, or calcification identified. And our other findings will be if the myometrium is like lacy or trabeculated, which could be indication that there's adenomyosis. Additional findings, so that will be talking about our fallopian tubes. So if there's any paratubal cysts, you can see a few on the PowerPoint image there. And then as well, we'll see if there's any cysts on ours. This one doesn't look like there's any obvious large cysts at all, but you can see those cysts on the PowerPoint there. So we'd be measuring those and giving an approximate number. If we had our ovaries, we'd also be talking about those and stating if there's any cysts or masses identified. And then our ink code. So at our institution, we only ink typically for pre-malignant conditions or malignant conditions. So because this one is a benign hysterectomy specimen, we did not ink our resection margins. Our resection margins would be inked if it were out for one of these conditions. They would be black for the posterior resection margin. So that would be all of this cauterized area here. And then green for our anterior surgical margin. So that would be all of this cauterized area here. So our sections that we would be submitting for a benign hysterectomy specimen would be our anterior cervix, posterior cervix, a full thickness section of the anterior endomyometrium, a full thickness section of the posterior endomyometrium. If we had any myometrial nodules, we'd be submitting sections of those. And then we do our fallopian tubes submitted as modified CFIM protocol. And I have a few images coming up later showing exactly what this modified CFIM protocol is. Now we'll go into how we actually section these specimens. So this is one half of the uterus. So we would section going superior to inferior, making these nice transverse sections until we got to the cervix where we would do a longitudinal cut. So once we've made all of our cuts, we would lay out our specimen and it would look something like this. So you can see all of those nice sections there going all the way down to the cervix, which we would have cut taking a longitudinal section of. Here's a zoomed in photo of one of those cross sections there. So the endometrium is at the top there. So to get our endometrium thickness, this is where we would be measuring it. And typically it's only about 0.1 to 0.2 centimeters in thickness. The myometrium you can see is right underneath that endometrium. And so we would be measuring the thickness from the endometrium all the way to the serosa for the myometrium. And then the serosa there is on the outside. So for our sectioning, we'd want to take a full thickness section. So that would go from the endometrium, including the myometrium, all the way to the serosa. And if this section was a bit too big to fit into our cassettes, then we would just bisect it across and fit it into 2 cassettes. And also just for interest's sake, so You guys might be noticing that this cut surface of the myometrium is very trabeculated and lacy. So this case is out for adenomyosis. So now we'll talk about the fallopian tube sectioning, which we do a modified CFIM protocol. So CFIM stands for sectioning and extensively examining the fimbriated end. So for our sectioning, we would do cross sections of the tube. Up until the fimbriated end, we want to amputate that off at about 1 centimeter. And then we would cut that fimbriated end longitudinally. So we bisect it. And then we would get our sections that look like this. So we have our tube with all the cross sections and that fimbriated end longitudinally bisected. So the modified CFIM protocol includes submitting the fimbriated end in toto with these longitudinal sections and 2 cross sections of the tube. The full CFIM protocol is submitting the entire fallopian tube with longitudinal sections of the fimbria that are then perpendicularly sectioned. So like this here, because we want to have greater surface area. So the full CFIM protocol is typically done for women with high risk of ovarian cancer. So patients with a BRCA1 or BRCA2 mutation, because early papillary serous carcinoma can be found in the fimbriated end. And so here is a sample growth description of a benign hysterectomy specimen. So the first paragraph there is just showing what the specimen is with all of our measurements. Then our next little paragraph there is talking about the uterus, so the serosa, external os, ectocervix, endocervical canal, and then talking about the endometrium. So for that case, we did have a polyp, so we talked about that and identified where it was located, so the anterior half of the endometrium. And then the myometrium, we talked about all of its findings. And then the fallopian tubes, we talked about the paratubal cysts. And then here is our section code. So we did our anterior cervix, posterior cervix, the anterior endomyometrium with the polyp in toto. So we always want to submit the polyp entirely because it could harbor some type of hyperplasia or even a small foci of cancer. And then we did our posterior endomyometrium, myometrial nodule, and then the cystic and lacy myometrium, and then our fallopian tubes using that modified CFIM protocol. So that is all I have for today. I just want to thank everyone for attending all of these sessions. Thank you all.